He is going to talk about Diabesity, therapeutic options. Sir is the head of the Department of Endocrinology and Diabetes and Clinical Pharmacology at University in Croatia. He was visiting scientist at St. Michael's Hospital in Toronto, Canada, Mayo Clinic in US, Moto Clinic in Czech Republic. He is a visiting professor at Faculty of Medicine at University of Macedonia. He served as a board member and secretary of IDF Europe and in 2015 and 17. To share my views, I had attended I had attended Sir's lecture in 2017 in Abu Dhabi when he was conducting an insulin session about something. So since then I have been knowing him. He served as a board member and secretary in IDF Europe. He is a president in Croatian Society for Diabetes and Metabolic Disorders, associate and chair of IDF Young Leaders in Diabetes program. That was, I think so, the program which was done in Abu Dhabi. Then he's published several chapters in Croatian and international books. He was invited speaker at many Croatian and international conferences. He was he participates in teaching of students at Faculty of Medicine, Faculty of Food Technology and Biotechnology, and Faculty of Pharmacy and Biochemistry. He received Young Investigators Award by Diabetes and Nutrition Study Group, ESD, and Rising Star Award in Croatian Endocrine Society, Award of International Collaboration by Macedonia Scientific Association of Endocrinology, and IDF Award for Outstanding Services. So, sir, Dario, sir, I would like to invite you to further enlighten us about the diabesity. Yes, sir.
Good afternoon to everybody. Thank you very much, Dr. Mishra, for your kind introduction. It was my pleasure meeting you in Abu Dhabi and also in India when I was in India several times. First of all, I would like to express my gratitude to my dear friend, Dr. Banshi Sabu, and I hope that we will see each other again in Croatia and in India very soon, hopefully. So, dear ladies and gentlemen, in the next 20 minutes, I will try to present diabesity as a problem which we can notice everywhere. These are my disclosures. So in the past, we had completely different attitude to weight like we do have right now. In the past, you can see that being obese was something gorgeous, something very respectful. And today, we think that obesity is a disease, and we know that obesity is disease. So we have completely changed our attitude to the weight. But obesity is a chronic disease with a complex etiology. I will not go into details. Of course, we have a problem and we have genetic predisposition, but also epigenetics is very important in being obese. On the other side, not just diet and inactivity, but emotional factors, lack of sleep, cultural, cultural attitudes, but also endocrine disruptors can cause obesity. On the other side, obesity is associated with many complications. You can see it here, just a few of them, but there are many others, and we can divide them in metabolic, mechanistic, and mental disorders. And today we heard about fatty liver. In this session we had fetal reprogramming, what is also important and connected with obesity. Fatty liver is just one small part of obesity associated complications, but also we are all aware of cardiovascular comorbidity in people with obesity and also type 2 diabetes. On the other side, obesity is a chronic condition with serious implications for life expectancy. And you can see here that people who are obese with BMI between 30 and 35, their life expectancy is reduced up to 4 years. But with BMI above 40, their life expectancy is reduced up to 10 years. Obesity is the second leading cause of preventable death, and we know that it's a global problem. More than half of the world's population is overweight or obese, and we can see it here that almost 2 billion people are overweight and more than 650 million are obese. In United States, the prevalence of obesity is up to 40%, and the population of in European Union is pretty the same. And you can see it here, different countries, and Malta, Latvia, Estonia, and United Kingdom, they have the highest proportion of overweight and obese women in EU. You can see it here in Croatia, 16.8 are obese and almost 32% are overweight. In men situation is even worse, and you can see it here, the proportion of overweight and obese men in EU are pretty high, and Croatia has the highest proportion of overweight and obese men in EU, unfortunately. Obesity is a rising public health, clinical and scientific challenge, and we know that today we have obesity crisis. On the other side, a number of people with diabetes worldwide is increasing, and according to latest IDF Diabetes Atlas, we know that last year we had more than 460 million people with diabetes, and till 2045, the number of people with diabetes will rise up to 700 million. Maybe numbers are not so important, but when we look at numbers on the another way, every 3 seconds one person gets diabetes, and every 6 seconds one person dies due to diabetes-related complications. In that case, we know that numbers are important. And we know on the other side that classification of obesity is according to BMI, and we know how to calculate BMI, but we have a problem when we look only on BMI. In elderly people, we have sarcopenia, and in elderly people, BMI underestimates cardiometabolic risk. On the other side, athletic body composition, BMI overestimates cardiometabolic risk. So it's much more important to take into consideration weight circumference instead of BMI. You can see it here, two men who had the same BMI, 26, and one of them was overweight and another one was athletic. So we have to take into consideration waist circumference instead of BMI. So it's not realistic, of course, being athletic and overweight. Waist circumference for people are different according to different ethnic specificity. You know that in United States, in Caucasians, and also in people in Asia, is different waist circumference, which is a specific indicator of cardiometabolic risk. So the most important thing, so we know that we have to diagnose obesity, and according to MKB 10 revision of classification, obesity has its own diagnosis code E66. Here is a diagnostic algorithm. So anthropometric criteria, not just weight, not just BMI, but also waist circumference can diagnose obesity, which will have a health impact of obesity and also weight-related complications. And as I already mentioned, there are many different clinical components of medical diagnosis of obesity. And we know that when we speak about obesity, we know that obesity is almost equivalent of diabetes, of type 2 diabetes, and is equivalent of metabolic syndrome. At least with pre-diabetes. But also we know that dyslipidemia, hypertension, cardiovascular disease, non-alcoholic fatty liver syndrome, polycystic ovarian syndrome, female and male infertility, and also obstructive sleep apnea are slightly connected with obesity, even with overweight. On the other side, also osteoarthritis as a mechanistic problem, but also in depression as a mental component of obesity. We know that obesity and diabetes are parallel epidemics, and we know that 85% of people with type 2 diabetes are overweight or obese. So that's the reason why we call it diabesity as a new epidemic. And relation between BMI and risk of type 2 diabetes is well known, and you can see it here that even people who have normal BMI up to 23, they have increased risk of type 2 diabetes, and up above 25 or about 30%, 30 BMI kilograms per meter, square meter, it's very, very high risk of type 2 diabetes. On the other side, abdominal obesity increases the risk of developing diabetes. So it's not just the weight, but also weight circumference. And you can see it here, about 80 centimeters, and of course, about 90 centimeters weight circumference. The relative risk of type 2 diabetes is very high. Why is so connected? Because adipose tissue is an important endocrine organ, and we know that we have intramuscular, we have visceral adipose tissue, but and also we have subcutaneous. But the most important is visceral adipose tissue, because the visceral adipose tissue secrete many different hormones and many adipokines. And here you can see that obesity is not just the fashion problem, it's a problem with lots of different adipokines like leptin, free fatty acids, resistance, TNF alpha, interleukin 6, which can cause inflammation, endothelial dysfunction, insulin resistance, procoagulative state, but also can cause increased atherosclerosis. So obesity is well connected with atherosclerosis, and obesity, the type 2 diabetes, NAFLD, hypercoagulability, hypertension, dyslipidemia, and low-grade system inflammation, together with insulin resistance, can cause atherosclerosis. So that's the link between obesity and atherosclerosis. But there are many other health effects of obesity, as I already mentioned, and cancer is also connected with obesity, but also lower life expectancy and limited mobility, social discrimination, and also many different other health effects. And you can see here the cardiovascular health effects of obesity. As I already mentioned, insulin resistance, dyslipidemia, hypertension, left ventricle hypertrophy, endothelial dysfunction, systematic inflammation, left ventricle systolic and diastolic dysfunction, heart failure, coronary artery disease, atrial fibrillation, sleep apnea, albuminuria, osteoarthritis, malignant diseases. So we know that obesity is an important cardiovascular risk, and you can see it here that threefold higher cardiovascular risk is attributed to obesity with 80%. And we know that many different studies, like Swedish obesity study, nurses health study, which connected arterial hypertension, diabetes, obesity, and healthcare, and also cardiovascular disease. And we know that arterial hypertension is six times more common in obese patients, and it's linear increases of arterial hypertension prevalence with BMI. and you can see it here. But the same situation is with coronary artery disease. I already mentioned that, that adipose tissue is an important endocrine organ which secrete many different adipokines and cytokines which can influence on coronary artery disease, like interleukin 6, CRP, fibrinogen, TNF-alpha, PI1, and many others. And 30% of circulating interleukin 6 originates from adipose tissue. So it's very important to emphasize the importance of adipose tissue as an endocrine organ. On the other side, high BMI and, of course, abdominal obesity in childhood can be associated with accelerated atherosclerosis in adulthood. And we heard about fetal programming and the importance of intrauterine environment. And we know that epigenetics in intrauterine environment is very, very important and can influence on obesity in adulthood. On the other side, hemodynamics in obesity is also changed, and we know that total blood volume is increased, increases filling volume and filling pressure, preload, and also is decreased afterload, which can cause not just heart failure, not just coronary artery disease, but also heart failure. And we know that heart failure is a huge problem in type 2 diabetes, but also is a huge problem in obesity due to left ventricle diastolic dysfunction and left ventricle systolic dysfunction. On the other side, of course, eccentric left ventricle hypertrophy as well. On the other side, we know that diabetes is a cardiovascular disease, and we know that many landmark publications suggested that type 2 diabetes may be a cardiovascular disease risk equivalent, and people with no diabetes, they have increased, with the diabetes, they have increased risk for myocardial infarction, and it's almost the same as a risk of patient who had prior myocardial infarction and they don't have diabetes. So we know that diabetes is an equivalent of cardiovascular disease. We can ask ourselves why. Well, it's a good question, but it's a question for next at least few hours talk. But we know that diabetes and obesity are linked to cardiovascular risk due to hyperinsulinemia and insulin resistance, but also due to activation of sympathetic nerves, also endothelial dysfunction, glucotoxicity, and lipotoxicity, which can cause dyslipidemia, type 2 diabetes, hypertension, and increased risk of atherosclerosis. On the other side, many other factors contribute to increased cardiovascular risk in type 2 diabetes and also in obesity. And we know that it's not just hypertension and dyslipidemia, but also lipotoxicity and adipose tissue, which is important endocrine organ, as I mentioned, and also genetic predisposition and protein glycation. We know that life expectancy is reduced by 12 years in people with diabetes with previous cardiovascular disease. So people with diabetes, their life expectancy is reduced by 6 years. And if they have myocardial infarction, their life expectancy is reduced up to 12 years. So also on the other side, we know that heart failure is underestimated problem in diabetes and in obesity. And we learn that heart failure is very important consequence of type 2 diabetes and also obesity. And I will not go through into details, but we know that diabetes and hyperglycemia per se, or pre-diabetes, can cause decreased angiogenesis, changes in cellular metabolism, and also oxidative stress, which can cause apoptosis, necrosis, and diastolic dysfunction, which can cause diabetic cardiomyopathy. It's very similar with a cardiomyopathy in people who are obese. So there is no doubt that we have to treat obesity, and we have to treat diabetes, and we have to treat diabesity as itself. We also can search for any solution. Of course, is there any solution for diabesity? Yes, there is some solutions. We are not satisfied, because we know that when we target obesity, when we target diabetes, and when we target diabesity as a special case, we know that we have to target hyperglycemia, arterial hypertension, dyslipidemia, but also glucose variability, hyperuricemia, and lots of different hormones excess. And we learned from EMPA-RECT trial that we can influence on cardiovascular disease in people with diabetes. And we learned that using empagliflozin in very short period of time, the investigators succeed to decrease 3-point MACE for 14% and cardiovascular death for 38%, and also all-cause mortality for up to 30%, and hospitalization due to heart failure. On the other side, the GLP-1 receptor agonists confirmed in LEADER trial, SUSTAIN trial, but also REWIND, we learned that also GLP-1 receptor agonist can influence on cardiovascular death and cardiovascular risk modification. So that's the reason why in glucose-lowering medication in type 2 diabetes, we know that if we have predominant atherosclerotic cardiovascular disease or chronic kidney disease, we know that we should treat those patients with GLP-1 receptor agonist and SGLT2 inhibitors. But on the other side, we know that proper diet and lifestyle changes is also important in type 2 diabetes, but also in treat diabesity. And that's the reason, of course, we always say it's important to reduce energy intake by up to 1,000 kilocalorie per day, physical activity at least 150 minutes per week. But when we talk about diet, we have to ask ourselves which diet to choose. And we know that many different diets are popular. And you can see it here that we have high carbo diets or high proportion of carbohydrates, and also low proportion of carbohydrates, like in Atkins diet. So we have different macronutrient profiles of popular diet. And we know that it was a trend in treating of obesity. 1970s sugar was bad, 1980s cholesterol was bad, 1990s fat was bad, and 2000 carbs or sugar are bad again. So that's the reason why we learned that it's important to emphasize the importance of diet, but which diet to choose. I found several interesting papers, and majority of those papers said any diet can work, but adherence is the key. So only adherence to diet can cause the weight loss. And also one study published in JAMA two years ago also compared effect of low fat versus low carb diet on 12 months weight loss program. And they found no significant difference in weight loss between low fat or low carb diets. And neither genotype pattern nor basal insulin secretion was associated with the dietary effects on weight loss. So the only problem is how to follow diets, not which diet we should follow. So key to weight loss is diet quality, not quantity. Because we can combine different foods, and we can increase the level of physical activity, and of course pedometer and also other stimulation for people how to increase physical activity is important. On the other side, get enough sleep, because sleep deprivation can increase hunger, can increase the opportunity to eat, because if you are awake, you have more opportunity to eat. alter thermal regulation, increase fatigue, and all those will increase caloric intake and also will reduce energy expenditure. So we will have obesity as a problem. So different studies show that sleep duration less than 5 hours is associated with obesity, but also chronic stress is associated with obesity with different pathophysiological mechanism, but more or less they cause high cortisol and also activation of adrenal gland and also sympathetic activation. On the other side, it's important to have cognitive behavioral therapy because we know that emotions have important things and behaviors on obesity prevalence. There are many drugs that produce weight gain, such as antidepressants, and especially tricycle antidepressants, and also some anti-diabetic drugs like insulin, sulfonylureas, and glitazones. And we know that weight effects of glucose-lowering therapy are well known. So that's the reason why we try to use weight-neutral or weight positive glucose lowering therapy, or glucose lowering therapy which is associated with weight loss, like GLP-1 receptor agonist and SGL2 inhibitors. That's the reason why even in algorithm for glucose lowering medication type 2 diabetes, also the compelling need to minimize weight gain or promote weight loss. Here is GLP-1 receptor agonists and SGL2 inhibitors. On the other side, when we talk about management of obesity in adults, according to European guidelines, we have several currently available medication for weight loss, and we use lorcetin or Belvic, also Qsymia and Saxenda, which are approved in Europe. And also bariatric or metabolic surgery, which is very important. Here are mechanism of bariatric or metabolic. It's better to say metabolic surgery because it's not just bariatric surgeries. Its impact on metabolism and metabolic effects are very important. So we have different altered GI signals to brain, endocrine, neural, and also altered GI signals to other tissues like in liver and pancreas. And here is the list of bariatric surgery and diabetes. And we know that up to 60% of people who had gastric bypass and who had metabolic surgery, up to 63% they have diabetes. They had diabetes remission. On the other side, 35 to 50% or more of patients who initially achieve remission of diabetes eventually experience recurrence. But it's important that with metabolic surgery, we can influence on diabetes remission. And here is the increased risk with the medications or surgery. You can see it here that realistic weight loss goals for dietary changes is up to 10%. With medication 10 to 15%, with endoscopic procedures up to 20%, and with bariatric surgery or metabolic surgery up to 45%. And we know that the benefit of 5 to 10% weight loss is reduction in risk of type 2 diabetes, cardiovascular mortality, improvement in blood lipid profile, and also blood pressure, and also improvement in severity of obstructive sleep apnea, and also quality of life as well. So since the majority of people with type 2 diabetes are overweight or obese, weight reduction is seen as a key therapeutic goal in the prevention and management of type 2 diabetes. Glucose lowering effect which support weight reduction should be the first choice after the obligatory metformin therapy. And we know that it's important to treat obesity. It's important to treat diabetes, but we must to prevent obesity and we have to prevent diabetes. And because we know that prevention is much better and more important than cure, like George always said, helping others is good, but teaching them to help themselves is even better, because our goal is to have people who are healthy and who live pretty long with no complication of diabetes, neither obesity. So people with diabetes have to treat their disease, because that's the only way how to achieve 100 years old life. Thank you very much, ladies and gentlemen.